All right, good afternoon and a very warm welcome to those in the audience and online to our session, which is on demographic and life stage vulnerabilities, issues, challenges and solutions. My name is Fulla Kopanides and I'm an Aspro in marketing here at RMIT and the chair for this session. Our session will run for about 50 minutes and we'll also allow for some Q&A time at the end, Q&A panel at the end of our sessions. We have three wonderful speakers for this session, and unfortunately, Associate Professor Amanda Beeston, who was delivering a session on customer vulnerability in the context of disability, will not be able to join us today, and we wish her a very speedy recovery. May I now introduce our first wonderful speaker, Associate Professor Joy Parkinson, who is a Principal Research Scientist with the Australian eHealth Research Centre CSIRO, and who will be delivering a presentation on the importance of recognising and addressing vulnerabilities in Australian health consumers through a health equity lens. Welcome on stage. Thank you.
Thank you very much. And thanks everybody for joining this session as well. Always a little scary when we split into two. But thank you so much for joining. Now, I'm just going to preface my approach this afternoon, and if I offend you, I don't apologise for that. Then my job is done, because today is about challenging our thinking and reframing how we approach consumer vulnerability and addressing that. So just to get started, the importance of recognising... Do I have a clicker here? Ah, yes. Don't worry, I have got glasses on, just can't see. So the importance of addressing and recognising vulnerabilities in Australian health consumers. And this is very much focused using a health equity lens. So I had originally planned to really talk about the language of vulnerability and how it can be paternalistic, can be stigmatising. We've had many of those discussions this morning, and so I don't really want to kind of revisit that. I think it is really important, language is really important, and my colleagues call me the language queen, because I'm constantly asking them to reframe what they're saying or to think about the language that they're using and who they're talking about as well. But I want to talk about, vulnerable, marginalised and underserved. So I know we're taking a strengths-based approach and we're talking about that. But that puts us in a very privileged position. And that's, I also want to talk about the lens that I'm bringing today. I haven't always been in a privileged position. I come from a town that is in a decile 1 CIFA, so very disadvantaged community. So if you're not aware of what that means, it's the poorest of the poor. I'm actually not first in family to go to university. My little sister beat me to it. I came to university as a very mature age student. So I do understand, what that actually means and what privilege means. So that's the lens I bring to all of my research. So I want to talk about moving from vulnerability to underserved. And there are many people in Australia who are actually underserved. And if we don't understand that and we don't address that, we can never get to health equity. So moving from focusing just on deficits to the challenges and then the opportunities that those challenges present. So today, as I said, very much focused on a health equity lens. So Rebecca talked this morning about, not when we're developing strategies, we shouldn't be developing homelessness strategies or strategies to address homelessness. We should be developing strategies for housing. So that's what a health equity lens is all about. It's a focus on the positive future. So this is a map of London, and this is showing how where we live actually determines how long we live. So no matter how much we talk about not just focusing on demographics, and trust me, I'm a marketer, I really don't want to focus on demographics, but there's an unfortunate truth in there that where you live really does determine how long you live. And if you can see the colours in here, it starts off with some pinks in the 70s and then moves through the shades of pink and red into greens and lighter greens and brighter greens. So the more affluent the suburb is that you live in, the longer you live. In Australia, and unfortunately the new CSIRO data has just come out this week after I'd already submitted my slide, so I couldn't add that nice infographic in. But in Australia, many of the most disadvantaged communities are in the more regional and remote areas, so far more in not in urban areas, and then the higher levels of advantage are in the more urban metropolitan areas. And the biggest proportion of disadvantaged people are from the Northern Territory and Queensland. Where do most of our First Nations people live in Australia? In those two states. Very interesting. So I just want that to sit with you. So sometimes thinking about demographics is important, but that's where we take a place-based approach. So that's where we're thinking about where people are, meeting them at where they're at in their communities. So many of the determinants of health are actually social determinants of health. And there's also the commercial determinants of health, and there's some wonderful research that happens here in Victoria about that. I've done a little bit of that, but they're doing some amazing work. And so that's really important as well, and it's that those interactions between the different parts in the system. There's so many things that are interacting. It's about all of those things that we can't change. Race and ethnicity, for example, where we were born. There's multiple things that we can't change, but we can put systems in place to help those people. I just want to tell you a little story about some of the work that I've done in Western Queensland in secondary prevention of type 2 diabetes. So these are people who've already got type 2 diabetes. In the group that I worked with, over about 12 months, there was a mother and daughter. And the daughter told a story about how she was looking after her grandchildren. She didn't look old enough to even have children, but she was looking after two of her grandchildren because her daughter was in prison, something I've not experienced. And so money was very tight. And she said, how can we eat healthy when it's so expensive to buy fruit and vegetables here? So what I do is I go and buy a loaf of white bread at the IGA. It costs 99 cents, some margarine and Vegemite. And the kids are happy and they're fed. And she also has other younger children that are still in school as well. So this is a story of a woman who's looking after her grandchildren. Her own mother is also there as well, and both of these women have type 2 diabetes. So if we don't address some of those things in their community and their access to fresh fruit and vegetables that are also affordable, then how can we expect them to make good choices about their health? We can't. There's other things that we have to consider. And I'm very fortunate that part of that work I did, we looked at the food and physical activity and health service environment in 25 different locations in Queensland, across all of the CSIRO quintile, so looking at the most disadvantaged and advantaged. And of course, the most disadvantaged people have the poorest access to all of the above. But Health and Wellbeing Queensland has taken that insight, and they're now actually working with suppliers to start to improve the access to healthier food, which is not always fresh. So promoting health equity. There's been lots of discussion today about, strengths-based approaches, which really is putting the agency a lot of the time onto the individual. But individuals also live in communities. So it's really important that we actually start to talk to people in communities, listen to how they can help people and what they can do. And this is an implementation approach. So looking at, on the left-hand side is, how can we come up with effective programs, and on the right-hand side is how can we get those out into the field, into the communities in an effective way. And because I've talked too much, I'm already running out of time. So how do we actually go about framing, understanding and informing solutions to address health inequities? So we've heard a lot of presentations and narratives this morning around listening to people and really taking that participatory approach. And that lived experience is so important to really understand where people are at and what could potentially help them as well. So we really want to, ground all of our research, whatever approach it is that we're taking in that lived experience, and taking trauma-informed approaches as well. So really understanding where people are at. And there's so many things that, as Australians, that's grounded in history that aren't things that we can change, but we can listen to people and we can understand where they're coming from, what's important to them, how things can change, and move away from basing things on our own assumptions. As part of some of the work I've done, I visited Thursday Island, which was a real privilege, and as part of that, Qantas, of course, this was before COVID, left our luggage in Cairns. So I was faced, with 2 days without luggage or toothpaste or anything. So I went to the one and only supermarket on Thursday Island and purchased a few essentials: toothbrush, toothpaste, deodorant, some clean knickers, a t-shirt to wear to bed, some yogurt and muesli. That cost $70. So if you're a mother that lives on Thursday Island and you have to make the choice between buying, new undies, the twin pack of Bonds undies cost $20. I've never worn them again, they're not that pleasant. How do you make that choice between buying your children underwear or school books or healthy food? It's not an agency thing there, is it? It's really beyond their control. So sometimes we've got to work in the system before we can ever start asking them to change or even helping them to change. So this is why we need to really understand, what are the mechanisms of change? What can we do to help people to, live a better life, a healthier life? So moving from old thinking to new thinking, we need to take a proactive approach. We need to integrate meaningful equity perspectives through historical and anticipated inequities. We really need to consider that. We need an authentic engagement, not just going to do interviews or focus groups because, and we've heard some great examples of how to do that this morning, just sitting and listening to people and building that rapport. Sometimes you can't do that straight away. Those women that I'm talking about who are Aboriginal women, and that's how they like to be referred to because I ask them. And I also want to touch on that when we talk about people first language. Are you a people with Aboriginal or are you an Aboriginal person? I think we have to be really careful and mindful of when we're using those terms. And I'm sure Maria will touch on these things later from, an Aboriginal woman's voice. I'm coming from a white woman's voice and a place of privilege, and I understand that. So it's really about incorporating that lived experience and co-creating with people in context. So we need to encourage a deeper level of thinking, and you're all here today, so you're already doing that. And then, more meaningful discourse as well. And I think this is a great place to start with that. And then that blind spot recognition as well. And there's so many, I could give you many examples of, where I've had those blind spots in my, experience. So an initiative that isn't intentionally equitable is unintentionally inequitable. Thank you.